Welcome you on our platform ISCT branch Nanded.
Thank
We
you.
started this activity as a celebration part with the Platinum Jubilee celebration of the ISA National. With that, our 25th year, like Silver Jubilee celebration of our ISA City branch Nanded. So, as a secretary, I thought that I should contribute to the private forum practitioners to give some opportunity with academics. So I started this case meets on every Friday 8 p.m. Somehow we have to come on today on Monday on this platform. This one is our 45th case meet, and I'm planning to do. I means our whole ISA City Branch Nanded are planning to do these case meets as a celebration part till 75th. So today, guys, we have one of the best stalwart in our MSCISA chapter, Dr. Naina Gadvi madam. She's a very great listener, a very great teacher, very much good mentor also, because I'm in IR, so she was the good mentor also. And she did a lot of work on even newer college like HBTMC. Hindu Hriday Samrat Basab Thackeray Medical College. She did a lot of work in that college also. She is actually a professor. She did MDD, NB, FCPS, DA, MNMS, PGT, HM, PGD, MLS. She is a great human, and she always come for our support. I seen at Borivali, she really gave her all efforts to do successful that CME, and it's a conference, I can say. Ma'am has almost published 11 chapters in 5 NSA books. This was a very great thing you did, ma'am. Even with that, she's a certified BLS, ACLS, PALS, and CCLS instructor. With that, she did almost 30 publications in various journals. Very great achievements, ma'am, you did. But with that achievement, ma'am is doing very much good things like Service to Humanity Award in 2016 for contribution in starting HBTMC. Ma'am also got a Mayor's Appreciation Award in 2017. Ma'am is a NMC assessor for PG and NAB examiners. Ma'am was Secretary of Staff Research Society of Hindu Hriday Samrat Balasaheb Thackeray Medical College. She is also a member of Curriculum Committee and Medical Education Unit. And with that, she is doing Skill Lab Coordinator as with HBTMC. So, ma'am, I'm really appreciate your work. With that, I'm welcoming on our platform at ISN Nanded City branch, and I'm really appreciate your work with it from all our ISA Nanded City branch members. I will welcome you on this evening. Screen is yours, ma'am.
Yeah.
Please.
Thank you, Dr. Sachin. So at the outset, first, thanks to Dr. Sachin Chandolkar for inviting me on this platform. He has been a very sincere student in Nair, and congratulations to ISA Nanded City branch for completing 25 years. I wasn't aware of that. So this is a very good activity you're doing for private practitioners, and he has told me many times, stick to basics. So I will stick to basics. And considering what private practitioners need, let's discuss that. Okay.
Yeah.
Let's not discuss very hi-fi, very big things which are not available or which are not accessible to private practitioners, but still in the range of their practice, how safely they can manage anesthesia of the airway surgeries. So let's start. So my topic today is anesthesia in ENT surgeries, how to safely share the airway. Okay.
Thank you.
Yeah. So the different ENT surgical procedures, you all know the list, right? From tonsillectomy, ear surgeries, nose surgeries, throat surgeries, thyroid, endoscopies, airway emergencies, lasers, laryngotracheal reconstructions. Now, all these surgeries, we have a varied age group ranging from pediatric to geriatric, and we have minor to supramajor surgeries. So the demand of anesthesia varies depending on the type of the surgery and the age group and the other problems of the surgery, whether it is an elective surgery or an emergency surgery. So just briefly in the beginning, let's go through the perioperative management in general about all ENT cases, and then let's discuss the problems and the remedies of specific cases. So how do we assess these ENT surgery cases? Similar to other cases, origin, duration, and progress of the disease itself. Along with that, we need to see what are the comorbidities which may affect our course of anesthesia. Related to airway, you have to see whether a patient is a smoker, has COPD, has asthma, airway sensitivity. Then if there are any addictions which may affect the airway, like tobacco chewing may cause submucous fibrosis, restricted mouth opening, smoking may cause increased air sensitivity. General examination, systemic examination, as we do in any other cases. Most important to us in these cases is airway evaluation, and that includes simple mouth opening, MPC, then your thyromental distance, hyomental distance, your neck extension, heavy chest, heavy jaw, all those things which will decide upon the grading of the difficulty of intubation or securing the airway. Investigations, all routine investigations for any normal surgery, but if it is going to be a major or a supramajor surgery, or if it is an emergency surgery in a diabetic hypertensive patient like retropharyngeal abscess or Ludwig's angina, then we need to go ahead with other investigations, like sophisticated investigations like renal and liver function test, blood grouping, cross matching, ECG. So remember all those things. Anesthesia concerns in all these surgeries where we do share airway with surgeons is that we are competing that space within that airway with our ENT surgeons. So small space, our tube is there, our circuit is there, surgeons are handling the tissues there, they are manipulating the airway, they are manipulating the head, neck. So we have to be on our toes all the time during these surgeries. So we cannot become lax during these surgeries. We are there can be frequent disconnections of the circuit. The drapes are there covering our circuit and our tube, so we have to be vigilant. The head is moved, the airway is manipulated, so there may be kinking, obstruction, extubation, or endobronchial intubation accidental during the course of the surgery. We have to, at the same time, we have to look at the surgical field also. There has to be lesser bleeding so that the surgeons finish their surgery fast. So controlled hypotension has to be given. Vital structures are there in the vicinity. The nasal area is very vascular. When the surgery is going on larynx, there are vessels around it. The larynx is itself important. So we have to be careful about all these things. And the irony in all these cases is that throughout the surgery, we have to maintain deep plane of anesthesia so as the patient is immobile, not coughing, bucking, moving during the vital steps of the procedure. At the same time, when the surgery is over, we have to rapidly bring the patient out of the anesthesia. He has to regain his airway reflexes. And
Ma'am, your screen is not able to seen by
yeah,
Manisha Kush, ma'am.
others can see.
Just can you please on reaction please do thumbs up like that. This I'm just shared
Please
this thing.
see if others can see the screen.
You do the thing.
Sachin, you can see.
I am able to see, ma'am.
Yeah.
So just Manisha Ghosh, ma'am, just mentioned that
Yeah. So
ma'am is
can
not
others
able
see?
to see.
They can just raise the hand so that I can know.
Yeah, 2-3 persons are. Yes, ma'am.
Yes.
2-3. Yeah, yeah. It's visible now.
It's
No
visible
issues.
now? Yeah.
Yeah,
Okay.
yeah.
Yeah.
Thank you.
Uh, so we were at the anesthesia concerns. 1 minute. Yeah. So at the end of the surgery, the patient has to be, so if we compare our intubation and extubation to the plane taking off and landing, then the landing has to be smooth and not jerky. So the emergence also has to be smooth. There should not be any coughing, straining, and there should not be any blood secretion, vomitus at the end of the surgery, so that the airway reflexes are intact and the airway is clean and clear. So our plan of anesthesia should be accordingly managed so that we have a deep patient intraoperatively, but alert awake patient at the end of the procedure. So anesthesia techniques, we all know: local anesthesia or nerve blocks or general anesthesia. Now here, one thing I want to mention: in ENT surgeries, whether you are doing a case on only monitored anesthesia care where local anesthesia is given and you are just monitoring, still you have to be very careful and very vigilant. Let's see why. So preoperatively, we have to prepare all these patients with steroids, antibiotics, local anesthetic if we are giving local. Even under general anesthesia also, many times we ask them to give local anesthesia along with adrenaline so as to reduce the bleeding and so the pain is less. So all these drugs are needed for pre-medication. Analgesics, then bronchodilators if indicated. Patient has to be fasting adequately. If it is an emergency surgery, yes, you really can't help it, but otherwise patient should be adequately fasting. And the IV access is most of the times on the left side, depending on which part of the ENT, throat or nose where we are operating. So in local anesthesia, we know all the three drugs which we use: lignocaine, bupivacaine, and nowadays ropivacaine is very popular because it is very cardio stable. So we avoid the cardiotoxicity of bupivacaine. But I don't know, most of you may not be still having ropivacaine easily available in all your small nursing homes, and you might be using bupivacaine and lignocaine. All these drugs, we have to keep in mind that we have to calculate the maximum allowable dose before starting with the local infiltration. Even if your ENT surgeon is giving the infiltration, ask the nurse what concentration she has taken, how much drug she has taken. It's always a good practice to calculate and keep a watch on what is being given and how it is being given, whether the surgeon is aspirating before injecting, because all this area is very vascular, and then the intravascular injection is very common. Many times we see after adrenaline, there is tachycardia, there is arrhythmia, and then you have to wait till the action wears off. So all these things are very important. Now, whenever you are, so the advantages of local anesthesia is that patient can tell you about the pain or discomfort. There is less blood loss and recovery is faster, and so you can discharge your patient faster. But you have to keep in mind that you have to carefully select the patients. Not all patients can be done under local anesthesia. If you are doing case under local anesthesia with MAC or sedation, still you need to optimize the physical status of the patient. You need to see the strength of the local anesthetic solution and the dose of the local anesthetic solution. Untoward effects of local anesthetic drugs, we all know. It's in lignocaine, it starts with numbness of the tongue and lightheadedness. That's why I said that you have to be vigilant. So if there is intravascular injection or if there is toxicity, you will immediately catch it early and then you will treat accordingly. If there are respiratory problems, severe depression, you will intubate, ventilate, and start with the vasopressors if needed. Now, with bupivacaine is the most cardiotoxic drug. So whenever you are using bupivacaine, please see to it that you have intralipid in your OT always available. So wherever you are visiting, wherever you are going, or your orthopedic surgeons or your ENT surgeons, you please keep one intralipid in your fridge and keep checking the expiry date. This is what we do in our OTs. It's a very simple thing, but very important. So in case of bupivacaine toxicity, the only treatment is intralipid 20%, which we give as dose of 1.5 milliliter per kg bolus. And then if needed, every 10 minutes we repeat. So this is the drug which we use where we can prevent the treat the bupivacaine toxicity. The bupivacaine molecule gets attached to it and then the action is nullified. So my request to all of you to have intralipid in your practice so that you don't have to run around. Then when we are using adrenaline, we generally dilute it in 1 in 200 ml. ENT surgeons, they have a habit of diluting adrenaline in 50 ml or 80 ml. So depending on what concentration is being used, you have to keep a watch how they are injecting, whether they are aspirating again and again, and whether they are waiting in between. Because if the adrenaline goes intravascular, then the arrhythmias can be detrimental many a times. So always keep a watch on how much drug is being given and how fast it is being given. Okay. Adrenaline is a very useful drug because it decreases blood loss. It delays the absorption of local anesthetic. So the action also remains for a longer time. And with adrenaline, you can use a higher dose of local anesthetic, but you have to be careful. Now, if I'm using a sedation for these cases, then I have to keep in mind that I have to give conscious sedation. So it cannot be deep sedation or minimal sedation. I have to give conscious sedation. Why conscious sedation? Because the patient should be sedated enough not to move. At the same time, should obey commands if you call out his or her name. So purposeful response to verbal or tactile stimulation and adequate analgesia. Now, why this is important? Because then your airway reflexes are maintained. At the same time, your patient is comfortable. The drugs which we use, all of you use the same drugs: midazolam, propofol, dexmedetomidine. Now, dexmedetomidine is a wonderful drug for all these ENT surgeries, but you have to keep in mind that you don't give bolus very fast. Many a times we have this habit of putting dexmedetomidine in a pint, and we don't know how much exact drug is going. If I have an infusion pump, then I know that over 10 minutes I'm giving bolus and it is going at the rate of 1 micrograms per kg. But when I'm using a pint and putting 100 drug in 100 ml, then I really don't know how much drug is going. So you have to be careful when you use dexmedetomidine, because the bradycardia is difficult to treat. And in opioids, most of you must be using pentazocine. But if fentanyl is available, then you can use for all these cases which are short and where you want awake patient at the end of the surgery. Always remember that whether you are doing MAC or sedation or general anesthesia, all ENT surgeries where you are sharing airway, your all resuscitation cart, difficult airway cart has to be there in the OT, so that you don't have to run around when the need arises, and vigilance for airway breathing circulation is must. If we are giving general anesthesia, there is nothing different to talk about. Again, the same preoperative, intraoperative management. Now, only thing which is important is you have to give antisyllagogue because secretions are more. So you give glycopyrrolate at 4 micrograms per kg. Antiemetic is must, so that if there are any secretions or blood seeps in and goes in the stomach, it does not cause nausea and vomiting. So give ondansetron, give pantoprazole, and give steroid to prevent airway edema. Always try to use short-acting drugs, but if they are not available, pentazocine is fine. Midazolam and pentazocine combination works well. Finargan and Fortwin combination works well in sedation cases. Induction standard, relaxant also standard. Now, depending on what type of case we are doing, we may give a spontaneous ventilation or controlled ventilation. We'll come later to that. Monitoring, standard monitoring, pulse, BP, respiratory rate, color, ECG, saturation, EtCO2. If you have NMT, then NMT monitoring. And if it is a supramajor surgery, then central line, arterial line, depending on the demand of the case. Maintenance, now here, depending on what kind of airway surgery we are doing, we either use spontaneous ventilation or controlled ventilation. In controlled ventilation also, we depending on our comfort, our experience, we can decide whether we want to use inhalational agent or total IV agent. If we want to give 100% oxygen, air and oxygen, depending on the type of the surgery. So at the time of extubation, thorough suction, no fresh bleeding should be there or pooling of blood should be there. Patient should be awake, calm, pain-free, and should meet extubation criteria and maintain saturation. Now let's quickly come to the individual surgeries, which are very important for us wherever we share the airway. So nasal procedures, there are different type of nasal procedures where we actually don't share airway, but our tube is under the drape, the neck is moved, the head is moved, and that's why the airway becomes important. So all these surgery where we are nasal surgeries where we have to be careful about airway are DCR, nasal endoscopies, then DICE procedure. So all these surgeries, we have to be careful about our anesthesia. So intubation is always with cuffed endotracheal tube. Tube is most of the times taken to the left side of the oral cavity, so it should be fixed very well. Try to use non-kinkable tube like flexometallic tube. If you want a tube in the center, then South Polar RAE tube is used preferably. If you don't have it, use your normal Potex tube and always pack the throat. So these are some of the photographs of the nasal surgeries where we have to be careful about the airway, and to decrease the bleeding in all these nasal surgeries, give little head elevation so that your field is better, the blood loss is less, and surgeons are comfortable. At the end of the extubation, always see to it that your pack is removed. See that how much your pack is soaked. If there is any fresh bleeding inside the oropharynx or nasopharynx, and then only extubate the patient. So post-operatively in all these nasal surgeries, you have to see to it that you give good pain relief. You prevent nausea, vomiting, because the blood seeps in slowly and patient swallows that blood, especially when he is under local anesthesia and sedation. So there is a tendency of having nausea. So give antiemetic as antacid. And if there is bleeding, you have to keep a watch on the post-nasal drip. If there is post-nasal bleeding, then you need to alert the surgeon and see what can be done about it. The complication in all these nasal surgeries can be airway obstruction due to nasal edema, laryngospasm, bronchospasm due to secretions irritating, and the nasal pack, if it comes out, then there is bleeding. There can be orbital compression and ecchymosis. CSF leak is again one complication of all these nasal surgeries. DICE is one procedure which is now come into practice a lot. Like we do many DICE cases in our institute where we need to diagnose the actual cause of OSA, obstructive sleep apnea, and then we have to then the surgeons have to decide about the corrective procedure. So in this DICE procedure, we have to take the patient inside. Generally these are obese patients who have OSA, history of OSA, and we have to induce a normal sleep. In that normal sleep, they do endoscopy and see whether there is a falling of epiglottis or falling of all the closing of the closure of the glottis due to falling all relaxation of the muscles around it. And then they decide the palatine procedures or medical management of this OSA. So in these patients, we have found that dexmedetomidine infusion with quiet, calm environment in the OT, switching off all the lights, and comforting the patient in the beginning. All these small things will help you with a smooth induction of sleep and not having deep sedation, so that the procedure can be done very well. Okay. Then nasal endoscopy, again we share airway, so we have to be careful about the smooth emergence and recovery. So if it is MAC, you just have to observe the local anesthetic injection and monitor the patient. If we are giving sedation, dexmedetomidine is a preferred drug. If you don't have dexmedetomidine, propofol also can be used in sedation dose. And if you are giving general anesthesia, throat packing is must, and you have to see that your tube doesn't kink or disconnect or there is no airway obstruction. Okay, so then coming to throat surgeries, most important, most common, which we do day in and day out, is tonsillectomy. Now in tonsillectomy, our goal should be to have a comfortable patient, comfortable surgeon, and comfortable us. So there should be good communication between all the three involved parties. Even the child's parents also matter. For that matter, parents also should be included. We have to give good pre-medication and provide excellent surgical access. At the same time, we are sharing the airway, so we have to be conscious about the airway protection also. We have to give good analgesia, prevent nausea, vomiting, and airway management is also of utmost importance. So the concerns in tonsillectomy are most of the patients are of pediatric age group. They may be ASA grade 2 because of their recurrent infection. They may be malnourished, or they may be low weight for their age. Then they have recurrent URTI, recurrent LRTI. They may have associated syndromes sometimes, and you have to look for history of bleeding tendencies also. And if they have adenoids along with tonsil, then the parent will give the history of snoring also. That means they have OSA, so you have to be careful. Sometimes the tonsils may be kissing tonsil. The intubation may become difficult in those patients. So in pre-medication, oral midazolam can be given safely, 0.5 milligram per kg, but you have to give it in the pre-operative room well before starting the surgery, so that the child is calm and quiet when you take the child inside. We can, again, another good drug is pedicloryl, which is very famous. Syrup pedicloryl can be given, so that patient is quiet when we take the patient away from the parents. But if those are kissing tonsils, if there are large tonsils, or there is a history of OSA, then avoid all this type of pre-medication. The other pre-medication is midazolam. I can give orally as well as intranasally. The dose differs. Okay. Fentanyl lollipop, I don't think it's, I mean, I have not seen, I have not used, so I've just mentioned it. Dexmedetomidine also is a fantastic drug if you are giving it orally or nasally in the required doses. Patient is absolutely quiet when you take the patient inside the operation theater. Intraoperatively, again, as I said, for any airway surgery, you have to have all types of tubes. So preferred tube is our RA tube, if not our regular endotracheal tube, which we use regularly. Suction, oral airways have good IV access. What is important in these cases is monitoring. So you have to monitor the saturation and the EtCO2. If there is disconnection, you will come to know with the EtCO2. If there is obstruction, you will come to know with the slope, looking at the slope of the EtCO2. If there is pressing on the tube, especially when that Boyle-Davis gag is put, your tube may get kinked or pressed or displaced during the surgery. Whenever they are moving, we are shifting tube from one side to another side, and again from this side to earlier side. So you have to be careful about the disconnection and the kinking. Okay, and propofol is the preferable drug of choice. Now, the most common complication with tonsillectomy is post-tonsillectomy bleed. So in this post-tonsillectomy hemorrhage, we have to see, of course, these are the problems, I mean, risk factors where the bleeding is more after the tonsillectomy. And how do we manage this tonsillectomy bleed? Your ENT surgeon will give you a call after 2 hours that patient is having bleeding and come fast. And then you have to rush fast to give anesthesia to this child who is now converted from routine surgery to emergency surgery. So most of the times it is managed non-operatively by packing or by doing some cautery. But if not, then we have to take the patient inside and induce it as an emergency surgery. So pre-operatively, again, see, you have given anesthesia once to this child. So you know everything about the child, what drugs you have used, how much time it has taken, whether child was awake or not. So immediately have a rapid re-evaluation and start your resuscitation along with. So have good 2 IV lines and start with, look at the vital signs, ask for blood grouping cross matching, and then you estimate the blood loss, see if there is a swallowing of the blood, vomiting of the blood, and then you gauge, see if the child is looking pale, then you know that the bleeding is too much. And then you have to start resuscitation with oxygen, good 2 IV lines, give bolus of ringer lactate 10 ml per kg as and when needed, and look for the improvement in the parameters. Send blood for grouping cross matching CBC. And if the hemoglobin is less than 8, then you have to transfuse the blood. If it is a major hemorrhage, then you have to ask for FFP and platelets also. So continue resuscitation. Meanwhile, you have to intubate this patient. Now, how you are going to intubate? Because airway is going to be difficult in this case. There is a lot of bleeding, so there will be blood in the mouth also. Now, this child should be considered full stomach because he has swallowed a lot of blood. So then this has to be a rapid sequence intubation with your anesthesia induction drugs and succinylcholine, and intubate as fast as possible. Put Riles tube so that you can aspirate the blood out and there is decompression, gastric decompression, and there is no the chances of aspiration are minimal. Okay, have two suction devices preferably, so that you have one suction with you and the surgeon has suction with him, and don't share the suction as far as possible. Fine. And if the bleeding is controlled immediately, then use cuff tube as far as possible. If the child is small, you don't have cuff tube, you have to use uncuffed tube, but pack the throat. And then when the bleeding is controlled, once the bleeding is controlled, then you have time in your hands to then resuscitate further, check the vital signs, continue giving IV fluids, if needed give blood. And then once the bleeding is controlled, your surgeon is happy with that hemostasis, then you reverse and extubate the child and give antiemetic and see to it that your patient is awake at the time of extubation. Post-operatively, monitor the child for recurrent bleeding, send coagulation profile, send hemoglobin, and as far as possible, don't give opioids because that causes sedation. So for pain relief, give NSAIDs so that child is awake and pain-free. So this is about bleeding tonsil. Next, we come to Ludwig's angina and retropharyngeal abscess. Again, a airway emergency. Many a times you are called in the night and the patient is inadequately fasting, has a lot of comorbidities like hypertension, most of the times diabetes, which is uncontrolled. But you have to drain the abscess. So this becomes a very tricky situation. Now, in these cases, now let's see what is the difference between two. Ludwig's angina is when the abscess is formed at the floor of the mouth below the tongue and it extends anteriorly. And retropharyngeal abscess is something which is formed behind the posterior pharyngeal wall and it extends in the oral cavity. Now, both the cases are emergencies, surgical emergencies, and both the cases have compromised airway most of the times. So whenever such patients come to you, you have to rapidly evaluate, see the comorbidities, see the fasting status, see the patient may be dehydrated because he's not able to eat or drink for 2-3 days. So you have to have IV line, fluids, all those things are important. But along with that, how we are going to manage the airway, that is most important part. Most of the times, if you are in a small setup and you feel that airway is very difficult to manage, please go ahead with elective tracheostomy. There is no harm in asking for elective tracheostomy beforehand only. After the abscess is drained, there is a lot of edema, lot of swelling. So managing airway is really difficult. And if you don't have fiber optic, then go ahead with tracheostomy. After 2-3 days, when you do redo or when the whole edema settles, then you can always decannulate the patient. The other way of managing airway is awake blind nasal intubation. Now you need to be experienced for that. You need to have a good setup for that and good assistance for that. If you have fiber optic, go ahead with nasal or oral intubation. Now all these things depend on how much is the abscess, if the mouth opening is adequate or not. If it's a retropharyngeal abscess, if the abscess is pushing ahead and it's in the intraoral, punctuating in intraoral cavity, then there are chances that while you are trying intubation, it may just rupture and patient may have pus in his oral cavity before securing the airway and he may aspirate. So you have to judge all these things before you decide your anesthesia. You have to discuss with ENT surgeon what is his thought about the case, and then you discuss and decide how you are going to manage your airway. Now you can do inhalational induction also. In fact, we have managed many cases like that. So we used to, that time we had halothane with us and thiopentone. So with that, we used to take the patient under, and in spontaneous breathing, we used to intubate. Now we have sevoflurane with us, propofol with us. So we can try inhalational induction. Again, with that, the problem is we have to have control on the breathing. So patient should not be deep that he hypoventilates or stops breathing. At the same time, patient should not be light that when you attempt intubation, he starts coughing and he goes into spasm. So play safe. If you're not sure about other techniques, go ahead with tracheostomy and peacefully do your case. There is no problem. If you are experienced enough and you have the equipment, the monitoring, the ICU backup, then you go ahead with awake fiber optic intubation. Now, fiber optic intubation, why it is the preferred technique? Because it can be done in sitting position. You just have to anesthetize the airway and then attempt the fiber optic intubation. So give topical, give lignocaine nebulization. Blocks are not possible most of the times because there is swelling, edema, you cannot see anything, anatomy is distorted. But always have ENT surgeon in the theater ready for tracheostomy in case patient goes into cannot intubate, cannot ventilate situation at any given point of time. And when you intubate the patient with spontaneous or with fiber optic, after the surgery is over, you have to take the decision of extubation depending on the extent of the abscess, the tongue swelling, the mouth opening, and then if needed, keep the patient on tube for some time, for a few hours till the edema settles, and then you can extubate the patient. Advisable tracheostomy is advisable, as I said, when fiber optic is not available, when you are not experienced enough to do fiber optic intubation or blind awake intubation, that is possible. And if the swelling is very huge with intraoral extension, if the patient is not fasting adequately, again, don't try many stunts in those patients. And dear friends, remember one thing, never fall prey to just a small nick. The ENT surgeon may be your spouse, maybe your friend, dear friend. He or she may say, I just need to take a small nick. No, if it is a small nick also, still you have to secure the airway, because out of 10 cases, 9 patients will not have any problem. But the 10th one, which will have problem, you may land up in a legal battle. So you keep that in mind and secure the airway. Always try to call one of your friends with you in such kind of difficult cases. Always have a thinking brain with you. It's always better to share your earnings than rather than, later share your worries. So this is about all these intraoral emergencies. Another intraoral emergency or tracheal emergency is foreign body in the larynx. So we get so many patients, children with peanuts, marbles, then toys, then coins in the cricopharynx. We get adult population with dentures in the esophagus or fish bone in the esophagus. So all these cases come for bronchoscopy and esophagoscopy. So rigid bronchoscopy and fiber optic bronchoscopy. Now, where do we use rigid bronchoscopy? For removal of foreign body most of the times, for biopsy, taking biopsy in a carcinoma or a growth, those cases. Now, all these patients who are done with rigid bronchoscopy, we need to give general anesthesia because there is a lot of mucosal stimulation, there is neck extension, there is a rigid scope which goes inside the larynx, so can cause a lot of spasm. So you need to give general anesthesia in these cases. Fiber optic bronchoscopy is most of the times used for diagnostic purposes. We use it for seeing the ideal, to see the larynx. It's a fiber optic bronchoscope is small, can be done, bronchoscopy can be done in local, can be done in supine or sitting position. So that is used in securing the airway. And rigid bronchoscopy we use for foreign body removal and for biopsies. Now, something about high flow nasal oxygen before we talk about bronchoscopy. Now, the recent concept is that whenever you are doing these airway surgeries, if you want to have apneic oxygenation or if you want to achieve apnea for a longer time, most of the times we do this coin removal, even bronchoscopies with intermittent apnea and intermittent ventilation. So we ventilate, we give relaxant, ventilate with 100% oxygen, we move away, and the ENT surgeon does his work. So during that time, if you want to increase that time of apnea, then give high flow nasal oxygen. Why? Because when you give standard oxygen with your nasal cannula, the FiO2 which is achieved in only 0.4% or 40%. So if I want to increase the FiO2, I have to increase the flow rate. So we can increase that flow rate by using a equipment known as high flow nasal HFNO, which became popular during COVID, right? So this is our HFNO machine where we can attach a nasal cannula and give high flow nasal oxygen. This nasal oxygen will continue to supply oxygen to the lung, and that will keep the oxygenation on during that intermittent apnea period also. And you can give more time to the surgeon to continue with this procedure. So now how we can give? Now, not everybody will have HFNO in their setup. So what we can do is use simple nasal cannula. Start with 4 liters oxygen. And as we anesthetize the patient, increase the nasal oxygen to 12 to 15 liters per minute, so that that oxygen is continuously going. Even when you are doing awake fiber optic intubation, give nasal oxygen continuously side by side, so that that oxygen with insufflation goes inside and maintains the saturation for a longer time. Okay. With that, let's discuss about bronchoscopy. You all know how we give anesthesia, so I don't have to teach about bronchoscopy. Let's just discuss what are the problems and how to tackle them. So we can give spontaneous ventilation. So we can keep the patient on spontaneous breathing under propofol, oxygen, and sevoflurane, and allow them to do the bronchoscopy. We can give apneic oxygenation, that is intermittently ventilate and allow them to do the bronchoscopy. Or the surgeon can use a ventilating bronchoscope, where there is a side arm to which we can attach the circuit and ventilate the patient. That is possible with ventilating bronchoscope. Alternatively, we can put a small endotracheal tube and allow the surgeon to put the bronchoscope by the side of that endotracheal tube and continue our ventilation with the endotracheal tube. The third way of using giving IPPV is Sanders jet injector. That is our Venturi. Fine. So spontaneous ventilation, induction is by inhalational along with IV. So we can give oxygen. Nitrous oxide is not preferred because, nitrous oxide is preferred so that patient remains deep. So oxygen, nitrous oxide, and sevoflurane. If you have halothane, go ahead with halothane. There is no problem. There is absolutely no problem using halothane. Only thing is that the patient remains deep for some time. And then use some amount of intravenous agent like propofol. We don't use any paralytic agent. Patient is breathing on his own. Only problem is that when they are doing bronchoscopy, air dilution occurs, rebreathing can occur, and patient can become light. So controlling the depth of anesthesia becomes difficult in spontaneous ventilation. And during lighter planes, the patient can go into spasm, laryngospasm or bronchospasm. So for apneic ventilation, you have a bronchoscope. To the side arm, you can attach oxygen and continue oxygen. As I said, continue oxygen and allow the ENT surgeon to continue with his bronchoscopy procedure. If we are using a side arm for ventilating the patient continuously during bronchoscopy procedure, then we need to keep the patient deep. Use relaxant, either IMS, that is you give succinylcholine. If your surgeon is very fast, give IMS, give scoline intermittently. Or if the procedure is going to take time, like peanut, which has now broken into pieces and surgeon is going to go inside multiple times, then use atracurium so that patient is relaxed, you are relaxed, and the surgeon also can comfortably continue his procedure. Then help them with the laryngoscopy. Many a times we only do the laryngoscopy and then the surgeon passes the bronchoscope after giving the neck extension, bringing the patient to the edge of the table, and then continue with our ventilation. Now this side arm ventilation, here they remove the glass eyepiece to complete the procedure. Now what happens whenever they are doing the procedure, when they remove the glass piece, our gases then are wasted through that opening. Then the surgeon also finds it difficult because the blast comes. Now, because of that ventilation interruption, there may be hypercarbia and respiratory acidosis. So always attach EtCO2. You will see CO2 rising, so that at the end of the procedure, you can hyperventilate, cause the CO2 washout before reversing the patient. There is resistance to the ventilation whenever we are ventilating with this side arm. So you have to see to it that you ventilate properly. Sometimes the exhalation is not complete, so air trapping may occur, the intrathoracic pressure may increase. There are chances of pneumothorax when you are using side arm ventilating bronchoscope. So keep all these problems in mind, keep auscultating the patient, look for pneumothorax, keep a watch on your SpO2 and EtCO2 continuously. Other problems with this ventilating bronchoscope is that too much of OT pollution, you keep inhaling a lot of sevoflurane, you feel sleepy at the end of case. Then hypoxia may occur if they are doing suction again and again, putting the scope again and again. So you have to, many a times you have to ask them to stop also in between so that you can ventilate properly. And sometimes it may happen that foreign body may just go down because of your ventilation. Third thing is, hello, yeah. So third thing is Venturi. So with Venturi, there is a needle which is attached to, hello. Yeah, so there is some disturbance. So when we are doing using a Venturi, this is the Venturi equipment. So in that we can continuously ventilate when when the person is doing, surgeon is doing bronchoscopy. So we can just put the needle in the bronchoscope from one side and use this pressure valve to regulate the tidal volume of the oxygen we are giving, the compressed gas which is going at the high pressure. Okay. Now, for jet ventilation, IV method is suitable. We really need not use inhalational. We can give propofol continuously, allow them to work, and keep ventilating with the Venturi. Earlier, when we were residents or lecturers, we used to work. We used to do a lot of ENT cases, laser cases in ENT hospital, where we used to get many patients of multiple papillomatosis, and those patients we used to ventilate with jet ventilator. So problems with jet ventilation is that air dilution occurs. It may cause hypoxia. If the lung is not compliant, then inadequate ventilation. Because the exhalation doesn't happen properly, there is chances of barotrauma, gastric dilatation, and the mucosal drying is there. So, and jet ventilator may not be available always. That is also there in private practice. So this is just to complete the list, but keep in mind that you can use jet ventilator. Now, this was about bronchoscopy. Esophagoscopy, if the foreign body is in esophagus or coin is in cricopharynx, then anesthesia is standard. Only thing is that you have to probably put a smaller size tube. If the coin is in cricopharynx, most of the times we don't intubate also. We just anesthetize the child and allow them to do the, many a times we only do laryngoscopy and remove the coin, and or allow them to do the laryngoscopy and remove the coin. But whenever we are giving anesthesia, keep in mind that you have to have good depth of anesthesia. There should not be any cuffing, straining on the tube, because a rigid scope is there in the esophagus and may cause esophageal rupture or perforation if the patient moves or bucks at that time. So you need to ventilate properly and allow the surgeons to do the procedure without patient becoming light. So post-operatively, all these patients you have to manage well, and you have to monitor them for longer time. Give 100% oxygen, check laryngoscopy and do suction under laryngoscopy. See that there is no bleeding, no edema, and extubate the patient only when he is fully awake. Give lateral position and humidified oxygen and nebulization. Last is laser surgery. Laser surgeries, you all must be doing a lot of laser surgeries. Now here, I will just tell you few anesthetic considerations. In laser surgery, you have to keep in mind that regular rubber tube or our usual endotracheal tubes can catch fire easily with the laser beam. So you have to avoid it by wrapping your tube with aluminum foil or copper foil. Nitrous oxide supports combustion, so use air and oxygen. Ideally is helium and oxygen. We don't have helium, so use air and oxygen so that your oxygen FiO2 is minimal, because again higher concentration of oxygen will help in catching fire. So don't use nitrous oxide, use air along with oxygen. And whenever you are doing laser, if it is a very small surgery, small nodule or just small lesion, then you need not intubate the patient. You can just ventilate, give apneic oxygenation and allow the surgeon to do the laser surgery. If you are using an endotracheal tube, then wrap it with the various material. or if possible, use a non-combustible tube. So the two tubes which are very much popular here in Mumbai, which we use regularly, we use this Teleflix tube in our OT. So this is a cuff in cuff tube where the inner cuff is filled with air and outer cuff is filled with saline. So if at all the outer cuff gets punctured by laser beam, the saline comes out. There is no fire and the inner cuff is there to protect the airway. Now then there is this other type of tube. There are again two, this is a rubber tube. This is a malleable stainless steel tube which has two cuffs, one after another. So with laser, if the upper cuff is damaged, at least the lower cuff is intact and the airway is protected. Along with that, keep in mind that use saline soaked patties around the tube, because whenever, if you are using normal tube, red rubber tube or Portex tube, though you cover the whole length, your cuff is unprotected. So always inflate the cuff with normal saline. And if there is puncture also, then you need to change the tube if you are using a normal tube. If you are using laser tubes, then there is no problem. Ventilation, if I'm not using a tube, intermittent apneic ventilation. If I'm using a laser tube, take all precautions. If I'm using a normal tube, again, you have to be more cautious. In case of laryngectomy, where you know that patient is going to go on tracheostomy, have a tracheostomy preoperatively so that you avoid all other problems. Now, in case of fire, if at all fire occurs, remove the tube. Ventilate the patient with 100% oxygen, give steroids, secure the airway, and then ventilate. Okay. Now, with this, now after discussing all these surgeries where we share the airway, one last thing which I want to tell you is get familiar with all our difficult airway guidelines. Our own Indian guidelines are there, IDA guidelines 2016. Why I'm saying that get familiar? Because these guidelines will always help you organize your thoughts at the beginning of any difficult airway case. It is like a path. It shows us a path that how many attempts you can do, where to stop, where to go to plan B, where to go from tube to supraglottic airway if device. If not that, then where to go to tracheostomy, when to call help. All these things are given in a very systematic manner, and they will help you organize your thoughts as well as organize your OT equipment, your anesthesia card, difficult airway card, as well as your crash card. So always use these guidelines to plan your anesthesia and always prepare in your mind before going for such cases. So with this, I want to conclude that whenever you are doing these cases where you are sharing the airway, it's a big responsibility on us because surgeons are busy doing their procedure. We are the ones, we have to take care of the airway. And if there is any slightest problem, bring it to the notice of the surgeon as early as possible so that you don't compromise on the airway. Keep difficult airway cart ready for every case. Always use short acting drugs. Try to use short acting drugs as much as possible so that you have a wide awake patient at the end of the surgery. High flow nasal oxygen definitely plays an important role. Start using it with simple nasal cannula. Always call for help if you are anticipating difficult airway. That makes your life easier. Thank you very much, and thanks for the opportunity. If you have any questions, please.
Thank you, ma'am.
I don't think there are any questions in the chat.
Yeah. Two questions are there.
Yeah, okay.
Yeah. One from our senior Dr. Naresh Pale also.
Yeah, sir. Good evening, sir.
Sir has mentioning about use of dex kit, combination of dexmed and ketamine as procedure sedation, especially for Ludwig Zagen.
So, yes, sir. So,
and with that foreign body removal also, more so in kids.
Yes. So about the first question, I think it's about a combination of dexmedetomidine and ketamine for Ludwig's
Yeah.
angina. Yes, sir. Dexmedetomidine is a wonderful drug which maintains your airway reflexes. So it's a good drug for conscious sedation. So if your surgeon is experienced and you are comfortable with him and you know that that airway won't be compromised, yes, we have also done and we are also doing cases under dexmedetomidine. I'm not saying that I secure airway in all the Ludwig's angina or I do tracheostomy in all the Ludwig's angina cases. So this can dexmedetomidine along with ketamine acts beautifully, maintains airway very well, airway reflexes very well. Pain relief is excellent. So patient doesn't move during surgery, during procedure. And if it is a quick procedure, then you can go ahead with this. But all this time, you keep in mind that you are ready with your tracheostomy tray along with.
Yeah.
Yeah. So if at all airway is compromised, sometimes it may happen that your abscess may rupture inside the mouth, and there may be chances of aspiration. Or patient may aspirate. Then you will have to secure the airway in emergency. Okay. And what was the second question, Sachin?
Ma'am, before that, I want to
Yeah.
share one thing that my wife having vocal nodule at
Okay.
almost 5-6 years back.
Yeah.
We went to Bombay Hospital, and
For
I
laser.
learned that for laser.
Yeah.
And that was the smiling face, and some sticker will put on the patient that you cannot talk for 24 hours, 48 hours, like that.
Yeah. Okay.
And I'm really lucky that one of the freelancing practitioner, very old person, I am not remembering that name also, but he shared a lot of things with on these issues.
Yeah.
That sharing the airways with a surgeon. I'm on that note. I want to ask you a question. We are now I'm very much luxurious period. I mean to say that we are using rocurium or atracurium like
Yes.
drugs that are very fastly reversible.
Yes.
But what about sedation part of the patient? That was the not happening now also. We are using Dexcate or like that things, or even Mizolam or like that.
Yeah.
But previously, these people did a really great job for immunity. Nowadays, what part of sedation you are using as ultra short acting drugs
So,
in
okay, I'll tell you. See, in our institute, we have fentanyl available because for government and municipal medical colleges, the license is not needed now as per the new amendment. So,
Okay, ma'am.
procuring fentanyl has become very easy for us. So, we have fentanyl. So, generally, for all these cases, we use fentanyl, midazolam. We may use or may not use. If I'm starting dexmedetomidine infusion, then I don't use midazolam. And along with
Okay.
midazolam, dexmedetomidine or midazolam, we use fentanyl and some amount of ketamine. So for sedation, if I'm using or doing the case in TIVA, then some ketamine. I think that much is enough for this. Only thing is that your airway should not be compromised.
Okay, ma'am.
But then anyway, when there is severe compromise of the airway, we go ahead with tracheostomy. We don't hesitate in asking for tracheostomy, though I work in an institute where I have everything available. Because certain cases you really cannot compromise.
So in private point of view, I am asking this question because we have to run for next case.
Yes.
So that patient should be awake. He should answer.
So dexmedetomidine really acts very well. Dexmedetomidine, and if you get fentanyl, fantastic, because again pentazocine acts for a longer time, and you don't want that. You want your patient awake. So dexmedetomidine is excellent. You can ask the surgeon to spray local or give some local, but again, when there is an abscess, that local hardly acts.
Yeah. Next question I will take, ma'am. How to prevent gastric insufflation in these procedures by Dr. Swati Shaw, ma'am?
Yeah. So all these cases when we are worried about gastric insufflation or gastric dilatation, always put a Riles tube inside and decompress. Let the RTB open. So if the gases are going inside, at least the stomach is completely getting decompressed. I have a policy of giving antiemetic at the beginning of the surgery so that the gastric motility is increased and gastric emptying is also faster, and give antacid. Fasting, yes. See that there is not too much of fasting also, because that causes a lot of acidic secretions, and that also can lead to aspiration. So there you have to see to it that you give oral liquids 4 hours before, so that there is not much of acidity. and give antacid and give antiemetic as a rule to all the patients, all these patients.
Yes,
Yeah.
yes, ma'am.
Yeah.
Yeah,
Simple,
even
simple things, but will definitely help you.
yeah, even you can ask to surgeon that that what I meant to say is scope. You can
Yes.
extract your scope for a while, and
Yes,
then
for a while,
it will
and then
be.
you can ventilate. Definitely,
Yeah,
yes.
yes,
If you are feeling that
uh,
your stomach is inflating.
yeah, very high. Yeah. Our senior member, previous secretary of ICCT brand Nanded, Dr. Dhananjay Maselgar asking
Hello.
how you prepare nasal tract for nasal intubation. Did you go ahead directly with nasal intubation, or you secure airway with oral intubation and go ahead with nasal airway?
No, whenever I want to do nasal intubation, then generally, see, we have fiber optic. So we nowadays do fiber optic only. So
Yeah.
in these patients, if I'm doing a fiber optic, then giving blocks is not possible. So we pack the nostril with adrenalized local anesthetic and then give nebulization. We give good nebulization outside the OT for 5 minutes with lignocaine. And that nebulization really acts very well, and that anesthetizes the tract. So we don't do oral intubation and then go ahead with nasal intubation. We do awake fiber optic intubation, nasal intubation.
Yeah, I'm remembering nowadays where
Yes,
whenever we go for nasal airway, the junior will do nasal what meant to say nebulization of that
yes,
patients.
nebulization. That
Yeah,
we used to
yeah,
use
yeah,
at
yeah.
that time also. Yes.
Yeah, we are
Then the
so much strict
lignocaine
on.
spray came. So then you
Yes,
can just put a tongue depressor and spray your posterior pharyngeal wall. But otherwise, nebulization, if you give by clock for 5 minutes, only thing is
yes,
that you
yes.
don't have to, you should not exceed the maximum allowable dose. I mean, don't go very high on the dose because the absorption is also faster and patient should not have toxicity. So pack and then you can give
I want to share with all of you. Just share with all viewers what you use for nebulization in these procedures cases for nebulization
yeah.
for
So
nasal intubation.
yeah, so we for nebulization we take whatever preparation we have this local anesthetic available, that we take around 1 cc and double diluted. So we have 2% lignocaine or 4% becomes a little more. So 2% lignocaine, around 4 ml total volume, and then you can nebulize. Only thing is that give nebulization in sitting position. If you keep him in reclined or supine position, the nebulization is not effective. So patient has to be sitting for the nebulization to act well. And always give anti-sialagogue drug. Earlier, when we used to do cases, we used to give intramuscular atropine half an hour before the
Yeah,
surgery.
yeah,
Now secure IV and give glycopyrrolate IV. Because if you have too many secretions intraorally, if there are a lot of secretions, then your nebulization, the drug does not act well because it is not absorbed
yeah,
by the
yeah.
nasopharyngeal and oropharyngeal area, because there are a lot of secretions and the drug doesn't act well. So that you have to be careful. So always give anti-sialagogue before doing going ahead with anesthetizing the airway tract.
Yeah. This is the thing you should must remember for all of us. Uh, our own member from Nair, Avijit Nair.
Oh, hi,
Everybody,
Abhijit.
sir
Abhijit
is
must be
a
having a very difficult question for me.
yeah, and he's asking, good evening, ma'am. You have
Hi,
covered the
good evening.
topic
Good
very
evening.
yeah, ma'am. What is your opinion and experience of using supraglottic airway (LMA) for tonsillectomy? Do
Yes.
you recommend it?
I have not used it anytime because I work in a medical college and I teach my PG students. So whenever I'm teaching my PG students, I teach them whatever is given in the books and whatever is the standard of practice. So I have never used LMA, but I know people who are using flexometallic LMAs, and you need to have that kind of expertise and experience also, because when you are using LMA, you have to see to it that your throat remains clear all the time whenever they are doing the tonsillectomy. Adenoidectomy, again, the problem is with your you have to have a flexometallic LMA so that tubing is flexible and the surgeon gets quite a bit of area to operate. So expertise is important, experience is important. So I have never done it, so I won't be able to really comment. But yes, many people are using LMS
LMS.
or yes, tonsillectomy. Yeah.
Yeah.
Because then
So,
the airway, see,
yeah.
airway stimulation is not much. All those advantages are there. Your drug requirement goes down, but then you have to take care of aspiration and all. Yeah.
Yeah. So on this note, I think sir has got the answer. Might be. Our next question from same Dr. Dhananjay Masalekar,
Yes.
ex-secretary of ISN Nanded. Any role of steroids in ENT surgeries for reducing edema?
Yes. Any role of steroids? Yes, definitely. We do have to give steroids as a rule, because whatever edema is there right from beginning, before the
Yes.
surgery, and
Yes.
whatever manipulation we do during the surgery, we money anesthetist with airway tube or securing the airway, and even
Yeah.
surgical also. So all their equipment, whatever is used in and around the airway, that definitely causes edema. So prophylactically, and that's why I mentioned that in pre-medication, along with our anti-sialagogue, anti-emetic, antibiotic, our steroid has to go. Then many a times these patients have hyperreactive airway because of their problem. So they
Yes.
may
Yes.
go into bronchospasm. So it is always better to give bronchodilators also along with that, with steroids in the beginning. So steroids, dexamethasone, and we continue post-operatively also, even in Ludwig's and all, to reduce the edema. We give dexamethasone, surgeons give dexamethasone 8 hourly till this edema subsides. So steroids have a big role to play in these all airway surgeries.
So, ma'am, which one is best, IV or inhalational steroids?
IV intravenous is definitely better, because the absorption, you know that the absorption is better and predictable. When you use inhalationals, you don't know how much is going inside. So you really don't know how much dose has actually gone in the system. So it is
Yeah.
always better to use IV. Inhalationals, it is useful when you want rapid action. So if there
Okay.
is a bronchospasm and I have a tube in place, then if I give 2 puffs to the endotracheal tube, definitely it is going to act immediately.
Yeah.
But
Yeah.
for long term, yes, IV steroid is definitely preferred.
So you regularly recommend for before
Yes,
surgery or
yes.
during the
Before
surgery?
surgery, you give, yes, and we give. I mean, we routinely give efcorlin as well as dexa, because efcorlin is short acting but faster acting, and
Yeah.
dexamethasone acts for 8 hours. So you give it for
We,
post-operative period also, and you need to
okay.
give antacid along with that, because you are giving steroids, so you have to give antacid.
Yeah, definitely.
Yes.
Ma'am, our own treasurer of MSCIC, Dr. Samir Sohni, sir, is asking
Yeah.
question. Yeah, sir, welcome on this platform, sir. Sir is asking nasal disc decongestant like xylometazoline, 10% lignocaine spray, or 2% lignocaine chili.
Yeah.
Which one is the best? I think sir has mentioned on that note. I'd like to ask on that note. I
We,
think.
yeah, we generally put first decongestant, so that there is the passage opens up and there is vasoconstriction, and then we pack it with local anesthetic, so that there is analgesia also. So you see
Okay.
to it that you use adrenalized lignocaine to pack, or you put otrivin and then pack with local anesthetic, so that there is vasoconstriction, so that there is no injury. If there is injury, there is not much of blood loss also.
Yeah.
There is vasoconstriction, the systemic absorption of your local anesthetic also goes down. So more drug remains in that area for a longer time. So the anesthesia of our nasal passage is also better. So we routinely use otrivin along with local anesthetic pack.
That to be 10% or 2%?
2%,
Jelly or
2%. 10% is too
2%?
much. Yeah, yeah.
Too much. So
Yes.
2% jelly with
2% is adequate.
xylometazoline?
Yeah,
Yeah, yeah.
jelly, yeah, jelly in that gauze piece. And first
And
we put otrivin and then we pack with local anesthetic.
if in case we don't have xylometazoline,
And we
atropine,
can use
so
adrenalized lignocaine, because adrenaline
adrenaline.
then causes vasoconstriction. Yeah.
Yeah, yeah.
And we can use more local anesthetic. Yes.
Okay. I think one last question. Sequential use. I already mentioned like thing.
Yeah.
What I madam mentioned is almost clear on that note. Really good things we learn from you, ma'am.
I
I'm
hope
really
I stuck to the basics and not spoke too many hi-fi things. Hopefully.
ma'am, yeah, ma'am. We are only ABC person,
Yeah,
not
yeah,
on work.
exactly.
Oh
No, no.
yeah,
Even in medical college also, we are not, we are also ABC people only.
yeah. So we do only basic things. Sometimes we don't
Yes.
have basic things.
The
Also, we
simple
have
things
to.
everybody has to keep in mind, that you have to keep calm. You
Yeah.
should always share. I feel if you have a difficult case in a remote area where no much help is there, of course,
Yes.
ENT
Yes. Yes.
surgeons do respect our decisions because they know how important airway is.
Yes. Yes. Yes,
So they
ma'am.
will always listen to you. But if you are in doubt, always call your colleague. That takes so much stress off your shoulders, and you can
Yeah.
think wisely. You can think better, you know. So always keep that in mind. And nowadays, you all are used to practicing together. That's a very good thing which we see now, and that's very nice. So you can always share your stress and do a case peacefully, you know, with a excellent outcome.
Yes. Yes, ma'am. Yes.
Yeah.
Yeah. Sony sir has mentioned that nice presentation useful for
Thank you,
private
sir.
practitioner. Yes, sir. I'm working on that only, sir. A lot of things are happening all over MSCSA and all over nation also. But private forum point of view, we are
Yes.
working on that thing. So
Yes,
from
we
ISA
have.
Nanded,
Yes.
yeah,
Yeah, I just want to say that we have too many hi-fi things now, and in
yeah,
conferences we speak about too many things which
yes,
are actually not applicable and not possible for private practitioners, not
yeah,
only small cities, even in Mumbai also.
yes, yes,
Even in Mumbai, not everybody has all the gadgets available to them. So it is better to stick to basics and try to improvise in that. Of course, if you
on
have
that.
more paraphernalia, it's
That
welcome.
was
If
a
you
great thing.
Yes.
Yeah,
If you
yeah.
don't have also, you
So,
should be able to give safe anesthesia.
yeah. Yes, even our secretary, past secretary, Dr. Dhananjay, is mentioning that thanks a lot, ma'am, and I say Nanded, such a wonderful session to attend. Thank you, Dhananjay. We regularly call like these stalwarts. They are doing a lot of things at private forum point of view and academic point of view also. And I'm really thank you that you attend this session, ma'am. I'm really appreciate your work on overall ISA point of view because you deserve a lot. Than you got, I think.
Thank you.
I'm really happy with this session, and all our members also very much happy with this. So I conclude this session with this note that we will meet again and again in future.
Thank you very
Thank
much.
you.
Yeah. Thank you, Sachin. Bye.
Thank you. Thank you, ma'am. Thank you.
Yeah.